This module is divided into 3 sections. Section A. Risk factors for nutritional deficiencies in children. Section B. Identification of malnutrition and micronutrient deficiencies. Section C. Nutritional interventions for preventing and treating malnutrition. By the end of Section A, you will be able to restate the health consequences of childhood undernutrition, understand the risk factors for nutritional deficiencies in children, and recognize the association between vegetarianism and risk of micronutrient deficiencies. Section B. You will identify symptoms of macronutrient and micronutrient deficiencies and describe clinical manifestations of classic nutrient deficiency syndromes. Section C. You will recognize nutritional interventions and World Health Organization guidelines for treating undernutrition and micronutrient deficiencies. Before we proceed with this module, let us first take a quick look at the global prevalence of stunting. Among the 3 key measures of undernutrition, namely underweight, stunting, and wasting, stunting is the best indicator of the cumulative effects of undernutrition and infection during the critical 1,000-day period. According to estimates by the World Health Organization, WHO, nearly 1 in 4 children, that is 23.2%, were stunted. Further, nearly 93 million children aged less than 5 years globally are suffering from the adverse impact of underweight, and undernutrition contributes to 45% of childhood mortality. The African and Southeast Asian region together account for an estimated 84% of the global burden of underweight children under the age of 5 years. According to the WHO estimates, undernutrition is highly prevalent in underprivileged children. The absolute difference in the prevalence of stunting between the richest and the poorest quintiles in 50% of the 77 low- and middle-income countries was 18 percentage points or more. The graphs on the right side depict the prevalence of stunting in 30 low-income and 35 middle-income countries by multiple dimensions of inequality, such as economic status, educations, and place of residence between 2005 and 2013. These statistics highlight the significance of understanding the risk factors, identifying the clinical manifestations, and appropriately treating nutritional deficiencies and severe acute malnutrition. The first section deals with risk factors for nutritional deficiencies in children. In this section, we will discuss health consequences of childhood undernutrition and risk factors for nutritional deficiencies, including those related to iron, vitamin A, folate, vitamin B12, zinc, iodine, calcium, and vitamin D. We will also discuss how vegetarianism can contribute to certain micronutrient deficiencies. The United Nations Children's Fund has defined undernutrition as the outcome of insufficient food intake and repeated infectious diseases. Undernutrition encompasses being underweight for one's age, stunted or too short for one's age, wasted or dangerously thin for one's height, and deficient in vitamins and minerals, that is, micronutrient malnutrition. Undernutrition during the early years of life can have a significant impact on all aspects of growth and development. While inadequate nutrition for a short period can lead to wasting, chronic undernourishment can lead to stunting. Additionally, poor early nutrition leads to impaired cognitive development, poor school performance and readiness, reduced immunocompetence, and increased susceptibility to infections and risk of morbidity and mortality. Undernourished children are at risk of developing into adults with reduced height, intellectual ability, and economic productivity. Undernourished girls are at increased risk of earlier childbearing. Undernutrition also increases the risk of developing obesity, diabetes, hypertension, and cardiovascular diseases in later life. Now let us discuss the general non-dietary risk factors for undernutrition in infants and children. Maternal factors which increase the risk of undernutrition in infants include poor health, nutrition, and physical status, environmental and psychosocial stress, short intervals between pregnancies, having several children, postpartum depression, low educational status, limited powers in making decisions, and unequal social status. Postnatal factors include frequent malaria, diarrhea, or intestinal worm infestations, and increased excretion of nutrients due to conditions such as schistosomiasis. Other factors include seasonal variations in the availability of foods, food shortages, social deprivation, and poor economic status. Let us now discuss dietary risk factors for undernutrition specific to infants and children. These include suboptimal breastfeeding, particularly non-exclusive breastfeeding during the first 6 months of life. Inappropriate complementary feeding practices, such as introduction of complementary foods at the wrong age. Low micronutrient density of complementary foods. Low intake of animal source foods. Consumption of a monotonous diet, which leads to low intake and poor bioavailability of micronutrients, especially minerals. And poor general nutrition status, especially protein-energy malnutrition. Having discussed the general risk factors for undernutrition, let us discuss the risk factors for specific nutrient deficiencies in the next few slides. Let us begin with risk factors for iron deficiency in infants and children. Prenatal or perinatal factors include maternal anemia during pregnancy, poorly controlled diabetes, multiple gestations, low birth weight, and prematurity. Parasitic infections which lead to heavy blood losses, such as hookworm, schistosomiasis, and ascaris, are also risk factors for iron deficiency. Dietary factors include breastfeeding without supplemental iron, early introduction of cow's milk or evaporated milk, use of low iron infant formulas, delayed introduction of iron-rich solids beyond 6 months, and low intake of heme iron present in meat, fish, poultry. Vitamin C enhances iron absorption from the diet. Hence, inadequate intake of foods rich in vitamin C, such as fruits and vegetables, also increase the risk of iron deficiency. High intake of cereals and legumes also increases risk of iron deficiency. Other factors include low socioeconomic and maternal educational status and exposure to lead. Factors which increase the risk of folate deficiency in infants and children include prematurity, feeding a diet poor in folate, such as goat's milk or boiled milk, congenital folate malabsorption, defective cellular folate uptake, and inborn errors of folate metabolism. Additionally, infants who undergo exchange transfusion are at risk of folate deficiency. Factors which increase the risk of vitamin A deficiency include low intake of dairy products, eggs, and beta-carotene from fruits and vegetables, and increased incidence of infections, especially measles and diarrhea. Additionally, poor nutritional status based on anthropometric measurement is also a risk factor for vitamin A deficiency. Iodine deficiency can occur due to low dietary intake of iodine. This occurs due to residing in areas with low iodine levels in the soil and water and living in high-altitude regions, river plains, or far from the sea. Increased consumption of natural goitrogens present in certain staple foods, such as cassava, can exacerbate iodine deficiency. Factors which increase the risk of zinc deficiency include malabsorption disorders, such as intestinal parasitic infections and persistent diarrhea, genetic disorders, impaired zinc utilization, low intake of animal products, and high intake of phytates, resulting in malabsorption of zinc. Vitamin B12 deficiency can occur due to genetic disorder of vitamin B12 metabolism, low maternal dietary intake, and/or vitamin B12 status in the nursing mother, or consumption of a strict vegan, lacto, or lacto-ovo vegetarian diet. Calcium deficiency can occur due to early weaning from breastfeeding. Low calcium content in the diet, usually less than 200 mg per day, low intake of dairy products or other calcium-fortified products, and increased consumption of grains and certain green leafy vegetables, which are high in phytates and oxalates, and reduce the absorption of dietary calcium. Furthermore, allergy to milk, transitioning from breast milk or formula to soda, juice, or calcium-poor soy drink, without an alternative source of dietary calcium, also increase the risk of calcium deficiency. Let us now discuss the factors which increase the risk of vitamin D deficiency in infants and children. A combination of inadequate cutaneous synthesis and poor intake contribute to vitamin D deficiency in infancy. Concerns about cancer, cultural beliefs, or neighborhood safety can lead to avoidance of sunlight, while increased skin pigmentation and ineffectiveness of the winter sun to stimulate vitamin D synthesis may contribute to reduced cutaneous vitamin D synthesis. Consumption of strict vegetarian or vegan diets, including unfortified soy milk or rice milk, poor intake of vitamin D fortified foods or foods naturally high in vitamin D, such as fatty fish, can also contribute to vitamin D deficiency. Severe maternal vitamin D deficiency during pregnancy due to poor dietary intake, lack of adequate exposure to sunlight, living at more northerly or southerly latitudes, and closely spaced pregnancies can increase the risk of congenital vitamin D deficiency in infants. Factors which increase the risk of vitamin D deficiency in children include low exposure to sunlight, excessive clothing, and the presence of darkly pigmented skin. Let us now discuss how vegetarianism can probably contribute to micronutrient deficiencies. Vegetarianism encompasses a range of highly diverse eating patterns and is characterized based on the degree of restriction of animal products. A vegan diet excludes consumption of all animal products and includes only plant foods, grains, nuts, seeds, vegetable oils, and legumes. Consumption of a vegan diet poses the highest risk for deficiency of certain nutrients during infancy and childhood. Consumption of very restrictive or unbalanced vegetarian diets can lead to failure to thrive and deficiencies, especially in energy, protein, vitamin B12, vitamin D, zinc, calcium, omega-3 fatty acids, specifically DHA or EPA, and iron in infants and children. A lacto-vegetarian diet excludes eggs, red meats, poultry or seafood, and includes milk and other dairy products, fruits, vegetables, grains, nuts, and legumes. Those on a lacto-vegetarian diet are at a risk of vitamin B12, zinc, and potentially iron deficiency. A lacto-ovo vegetarian diet excludes all meat, seafood, and poultry, and includes milk and other dairy products, eggs, nuts, legumes, grains, fruits, and vegetables. Those on a lacto-ovo-vegetarian diet are at risk of zinc, iron, vitamin B12, and omega-3 fatty acid deficiencies. An ovo-vegetarian diet excludes milk, dairy products, red meats, poultry, seafood, and includes eggs, nuts, fruits, vegetables, grains, and legumes. Consumption of such a diet increases the risk of vitamin D, vitamin B12, calcium, and zinc deficiencies. In this section, we will discuss clinical manifestations of protein-energy malnutrition and how to identify children with severe acute malnutrition. Kwashiorkor and marasmus are severe forms of protein-energy malnutrition. These two disorders are characterized by multi-system organ dysfunction and growth and developmental retardation. Children with marasmus have a frankly emaciated appearance and weigh less than 60% of the expected weight for their age. They appear alert until late-stage disease. The skin is usually thin and dry, with wrinkling due to loss of subcutaneous fat. Children aged less than 2 years are at the highest risk of developing marasmus. Children with kwashiorkor typically present with alopecia, flaky paint dermatitis, lightening of hair pigmentation, and generalized edema. They are irritable but may develop frank lethargy as the condition progresses. The body weight is usually greater than 60% of the normal weight for their age. Additionally, these children have a poor appetite, diffuse muscle wasting, with preservation of fat stores and fatty liver infiltration. Children aged 1 to 4 years who are weaned from breast milk are at an increased risk of developing kwashiorkor. A comparison of the clinical signs of marasmus and kwashiorkor is presented in the table. Let us now discuss how to identify children with severe acute malnutrition, or SAM. In 2013, the WHO updated its guidelines for the management of SAM in infants and children. Accordingly, in a community setting, trained community health workers should measure the mid-upper arm circumference, or MUAC, of infants and children aged 6 to 59 months, and also examine them for bilateral pitting edema. An MUAC lesser than 115 mm, or the presence of any degree of bilateral edema, indicates the presence of severe acute malnutrition. This is a strong recommendation with low-quality evidence from the WHO. In primary healthcare facilities and hospitals, the MUAC, or the weight for height or weight for length status, and the presence of bilateral edema should be assessed to identify SAM. An MUAC lesser than 115 mm, or a weight for height or weight for length z-score less than -3, or presence of bilateral edema indicates the presence of SAM. This is also a strong recommendation with low quality of evidence from the WHO. Early detection combined with decentralized treatment facilitates early treatment initiation before the onset of life-threatening complications. Now we will discuss how to identify deficiencies of iron, folate, vitamin A, vitamin B12, vitamin D, and calcium. Before we discuss the clinical manifestations of various micronutrient deficiencies, let us take a quick look at the global prevalence of micronutrient deficiencies. The most widespread micronutrient deficiencies globally include deficiencies in iron, iodine, vitamin A, folic acid, and zinc. According to the World Health Organization, nearly 43% of children, corresponding to 273 million children, were estimated to have iron deficiency anemia globally in 2011. According to 2013 data from UNICEF, globally, more than 35 million newborns were at risk of iodine deficiency disorders. According to 2017 evidence from the WHO, about 190 million children aged 6 to 59 months are vitamin A deficient. The highest prevalence was noted in Africa and Southeast Asia. Let us first discuss the clinical manifestations of iron deficiency, which is the most common nutritional deficiency across the world. Children with mild iron deficiency are usually asymptomatic. Children with moderate iron deficiency, that is, hemoglobin levels of 6 to 8 gram per deciliter, may have reduced appetite, fatigue, irritability, and reduced exercise tolerance. Physical examination may reveal pallor, tachycardia, and systolic ejection murmur along the left sternal border. A child with severe anemia, that is, a hemoglobin level less than 3 grams per deciliter, may present signs of congestive heart failure, such as tachycardia, S3 gallop, cardiomegaly, hepatomegaly, and RALS. Distended neck veins may be observed. In developed countries, clinical features such as glossitis, koilonychia, and angular stomatitis are typically not noted in children with isolated iron deficiency anemia. Now let us discuss the clinical manifestations of vitamin A deficiency. Eye lesions are the most characteristic and specific sign of vitamin A deficiency. Eye lesions due to vitamin A deficiency develop insidiously and are rare before the age of 2 years. In the early stages, vitamin A deficiency may manifest as a delayed adaptation to the dark, xerophthalmia, and Bitot spots. Keratomalacia and corneal ulceration develop during the later stages of vitamin A deficiency and lead to blindness. Skin manifestations of vitamin A deficiency include dry, scaly, hyperkeratotic patches, mainly on the arms, shoulders, legs, and buttocks. Other signs of vitamin A deficiency include anemia, apathy, diarrhea, susceptibility to infections, mental retardation, poor overall growth, and increased intracranial pressure, with wide separation of the cranial bones at the sutures. Bone overgrowth may cause pressure on the optic nerve and lead to vision problems. In this slide, we will discuss the clinical manifestations of folic acid and vitamin B12 deficiencies. Hereditary folate malabsorption may manifest as recurrent or chronic diarrhea, oral ulcerations, opportunistic infections, failure to thrive, megaloblastic anemia, and neurologic deterioration. Cerebral folate deficiency may manifest as microcephaly, irritability, developmental delay, seizures, blindness due to optic atrophy, cerebellar ataxia, chorioathetosis, balismus, or pyramidal tract signs. The clinical manifestations of vitamin B12 deficiency in infants and children are usually nonspecific and include feeding difficulties, lethargy, weakness, and a failure to thrive. Other clinical manifestations include pallor, icterus, vomiting, diarrhea, glossitis, and hyperpigmentation of the palms and knuckles. Common neurologic symptoms include developmental delay, irritability, developmental regression, involuntary movements, and hypotonia. Now let us discuss the clinical manifestations of vitamin D and calcium deficiencies. Vitamin D and calcium deficiencies cause rickets. However, rickets is more commonly associated with vitamin D deficiency. Nutritional rickets occurring in infancy and early childhood is usually due to deficiency of vitamin D. Rickets occurring due to dietary calcium deficiency is typically noted in children aged between 3 and 6 years or during the pubertal growth spurt, where it is usually referred to as adolescent rickets. Furthermore, rickets due to calcium deficiency is more likely to develop in children who are weaned early. Children with rickets usually present with variable clinical manifestations. The general clinical manifestations include a failure to thrive, listlessness, muscle weakness, protruding abdomen, and fractures. Skeletal manifestations include craniotabes, frontal bossing, delayed fontanel closure, craniosynostosis, scoliosis, kyphosis, lordosis, rachitic rosary, Harrison groove, enlargement of the wrists and ankles, valgus or varus deformities, anterior bowling of the tibia and femur, and leg pain. Other manifestations include delayed dentition, carious teeth, respiratory infections, and atelectasis. Children with vitamin D deficiency are at increased risk of pneumonia and muscle weakness, which may result in delayed motor development. Children with disorders that produce hypocalcemia may also present tetany, seizures, and stridors due to laryngeal spasms. Iodine deficiency can lead to a spectrum of disorders. In neonates, it can manifest as neonatal goiter, mental retardation, and neonatal hypothyroidism. Children and adolescents with iodine deficiency can present with goiter, adolescent or subclinical hypothyroidism, impaired mental function characterized by low intelligence, and retarded physical development. Zinc deficiency in children manifests as decreased growth, impaired immunity, poor wound healing, diarrhea, hypogonadism, dermatitis of extremities, and dermatitis around orifices. Let us now discuss the clinical manifestations of vitamin C deficiency, which is referred to as scurvy. In the early stages, the manifestations of scurvy include irritability, low-grade fever, loss of appetite, musculoskeletal pain, and tenderness in the legs. Subsequently, children develop swelling of the legs, which is most marked at the knees and ankles, and pseudoparalysis. The child might lie with the knees and hips in a semi-fixed position and the feet rotated outwardly. Subperiosteal hemorrhages may be observed in the lower limb bones, which may acutely increase the pain and swelling. This condition may mimic acute osteomyelitis or arthritis. Other typical features include rosary at the costochondrial junction and sternal depression. In children with dentition, gums appear bluish-purple, spongy, and swollen, especially over the upper incisors. Hemorrhagic manifestations include petechia, ecchymosis at pressure points, purpura, or perifollicular hemorrhage. Other manifestations include poor healing of wounds and fractures, hyperkeratosis of hair follicles, and muscle weakness. Niacin deficiency is referred to as pellagra. The classic symptoms of pellagra, dermatitis, diarrhea, and dementia, are usually observed only in adults and are typically not identified in infants and children. The common symptoms in children include anorexia, anxiety, apathy, and irritability. Children may also have sore tongue and lips, dry and scaly skin, anemia, and evidence of other nutritional deficiencies. Deficiency of thiamine manifests as a condition called beriberi. Children with beriberi present with pallor, restlessness, constipation, vomiting, poor mental concentration, and apathy. Symptoms such as restlessness, breathlessness, and bouts of screaming indicate cardiac involvement. The child appears pale but cyanosed. Pericardial and pleural effusion may be observed. Cardiomegaly and pulmonary edema may be observed on a chest radiograph. The aphonic form of beriberi, which is usually noted in infants aged between 5 to 7 months, manifests as distressing and increasing cough and choking. These symptoms are quickly followed by hoarseness, dysphonia, and aphonia, leading to a noiseless cry. children with dry beriberi or central nervous system involvement present with paresthesia, hyperesthesia, and burning feet. Owing to muscle weakness and tenderness, a child may find it difficult to get up from a sitting position. Subsequently, the child may experience ataxia and loss of deep sensation and coordination. Wernicke's encephalopathy, characterized by confusion, apathy, drowsiness, signs of meningism, increased intracranial pressure, and head retraction, is usually observed in children in the age group of 8 to 10 months. The third section deals with nutritional interventions for preventing and treating malnutrition. In this section, we will discuss the different nutritional intervention strategies to prevent malnutrition in children. We will also briefly cover the nutritional management of children with severe acute malnutrition. The Lancet series on Maternal and Child Undernutrition 2013 published a comprehensive update of nutrition interventions to address maternal and child undernutrition in countries with high rates of malnutrition. The slide presents a bird's-eye view of various nutrition-specific interventions which were evaluated for the evidence of benefit. The researchers selected 10 nutrition interventions seen in bold, such as periconceptional folic acid supplementation or fortification, maternal balanced energy protein supplementation, maternal calcium supplementation, multiple micronutrient supplementation in pregnancy, promotion of breastfeeding, appropriate complementary feeding, vitamin A and preventive zinc supplementation in children 6 to 59 months of age, management of severe acute malnutrition, and management of moderate acute malnutrition. They evaluated benefits achieved from these interventions by determining whether their coverage increased from their present level to 90% or was retained at their present coverage if it was already higher than 90%. Additionally, the researchers also reviewed other interventions. These are indicated in italics in the illustrations. The evaluation suggested that the current under 5 child mortality can be reduced by 15% if access to the specified 10 evidence-based nutrition interventions is scaled up to 90% coverage. Furthermore, they noted that increased gains can be achieved and that about a fifth of the existing burden of stunting can be prevented using these interventions with improved access. In subsequent slides, we'll discuss nutrition interventions for neonates, infants, and children. Let us discuss interventions to prevent nutrient deficiencies in neonates. These include delayed cord clamping, neonatal vitamin K administration, vitamin A supplementation, and kangaroo mother care. Delayed cord clamping. In term neonates, delayed cord clamping has been suggested to significantly increase newborn hemoglobin levels and lead to higher serum ferritin concentration at 6 months of age. According to WHO, cord clamping should be performed not earlier than 1 minute after birth. In preterm neonates, delayed cord clamping has been reported to reduce the need for blood transfusion by 39% and lower the risk of complications at birth. Although these strategies have been promising, they have not been evaluated for effect or feasibility of implementation in health systems. Vitamin K administration. WHO strongly recommends that all newborns should be administered 1 milligram of vitamin K intramuscularly after the first hour of birth. Prophylactic administration of vitamin K after birth prevents bleeding. According to a Cochrane review, a single intramuscular dose of vitamin K, when compared with placebo, was associated with reduced clinical bleeding at 1 to 7 days of life, including bleeding after circumcision. Oral and intramuscular vitamin K confer similar improvement of biochemical indices of coagulation status at 1 to 7 days. Neonatal vitamin A supplementation. Although neonatal vitamin A supplementation is associated with reduced infant mortality at 6 months of age, the evidence is contradictory and may be linked to maternal vitamin A status. Hence, the authors of the Lancet series warrant further evidence before any recommendations on vitamin A supplementation are made. Furthermore, WHO 2013 recommendations on newborn health do not recommend neonatal vitamin A supplementation, that is, supplementation within the first 28 days after birth, to reduce infant morbidity and mortality. Kangaroo mother care. It refers to early skin-to-skin contact between the neonate and mother at birth or soon thereafter, along with early and continued breastfeeding, parental support, and early discharge from the hospital. According to a Cochrane review, a 40% reduction in the risk of mortality, a 58% reduction in nosocomial infection or sepsis, and a 77% reduction in hypothermia prevalence was observed among preterm neonates who received kangaroo mother care. Let us move on to the nutritional interventions in infants and children. Promotion of breastfeeding and supportive strategies. According to a systematic review, initiation of breastfeeding within 24 hours of birth is associated with a 44% to 45% reduction in all-cause and infection-related neonatal mortality. Promotion of dietary diversity and complementary feeding. Evidence from low-income countries shows that consumption of a minimum acceptable diet with dietary diversity lowered the risk of both stunting and underweight, while consumption of minimum meal frequency was only linked to a lower risk of underweight. Iron supplementation. Iron supplementation in children under 2 years of age reduces the risk of iron deficiency by 76% and anemia by 49%. Vitamin A supplementation. According to a Cochrane review, vitamin A supplementation in children aged 6 to 59 months reduced all-cause mortality by 24% and diarrhea-related mortality by 28%. It also reduced the incidence of diarrhea and measles. Multiple micronutrient supplementation, compared to supplementation with 2 or fewer micronutrients, has been shown to confer small benefits on weight gain, linear growth, and some improvement in hemoglobin, reduction in iron deficiency anemia, and retinol deficiency. However, the safety and benefits of this intervention are yet to be established. Preventive zinc supplementation. Data from developing countries have demonstrated that preventive zinc supplementation reduces the incidence of diarrhea, pneumonia, and morbidity rates due to childhood diarrhea and acute lower respiratory infections. It may increase linear growth and weight gain in infants and young children. A daily dose of 10 mg zinc for more than 24 weeks in under 5 children may lead to an estimated net gain of 0.37 cm, or standard deviation of 0.25 in height in zinc-supplemented children compared with placebo. In children aged 6 months to 12 years, zinc supplementation has been reported to confer a positive effect in reducing all-cause and infectious disease mortality. Further, it has also been shown to be associated with increased skin fold thickness in full-term infants. According to a Cochrane review, zinc supplementation during pregnancy was found to result in a 14% relative reduction in preterm births, especially in trials involving women with low income. However, there was no convincing evidence that zinc supplementation during pregnancy would result in other useful and important benefits, such as prevention of low birth weight babies. These findings highlight that trials which address ways of improving the overall nutritional status of populations in impoverished areas, rather than focusing on just micronutrient supplementation, should be an urgent priority. Deworming. According to a systematic review, one dose of a deworming drug for confirmed soil-transmitted intestinal worm infection has been reported to increase weight and hemoglobin levels. Several emerging nutritional interventions are being evaluated. Although these interventions are not currently recommended, they have been observed to have possible effects on nutritional outcomes in women and children. The different interventions include antenatal supplementation with omega-3 fatty acids, vitamin D, and zinc. In infants and children, the different strategies being investigated include supplementation with zinc, in addition to antibiotics, to treat newborn infections and childhood pneumonia, vitamin D supplementation in high-risk populations, including infants and toddlers, and providing lipid-based nutrient supplements to children along with normal diet. Additionally, consumption of biofortified yellow cassava has been shown to confer a modest increase in serum retinol concentration and large increases in beta-carotene concentration among children aged 5 to 13 years. There are other non-nutrition interventions, such as reduced exposure to household air pollution, that are linked to adverse child health outcomes, including low birth weight, stunting, and all-cause mortality. Among preterm infants, body massaging has been linked to positive health outcomes. The extensive review of interventions published in the Lancet series reaffirmed that several feasible low-cost, evidence-based interventions are available to improve maternal and child nutrition. However, the coverage of these interventions is far from satisfactory. Now we will discuss essential nutrition actions recommended by the World Health Organization for improving newborn, infant, and young child health and nutrition in countries with high rates of undernutrition. These recommendations were published simultaneously with the 2013 Lancet series on maternal and child undernutrition and provide updates on evidence-based interventions. Infants should be exclusively breastfed for the first 6 months of life. Thereafter, to meet the increasing nutritional requirements, infants should be offered nutritionally adequate and safe complementary foods while breastfeeding continues for up to 2 years of age or beyond. WHO Guiding Principles for Complementary Feeding of the Breastfed Child. 1. Practice exclusive breastfeeding from birth to 6 months of age and introduce complementary foods at 6 months of age, or 180 days, while continuing to breastfeed. 2. Continue frequent on-demand breastfeeding until 2 years of age or beyond. 3. Practice responsive feeding, applying the principles of psychosocial care. 4. Practice good hygiene and proper food handling. 5. Start at 6 months of age with small amounts of food and increase the quantity as the child gets older while maintaining frequent breastfeeding. 6. Gradually increase food consistency and variety as the infant gets older, adapting to the infant's requirements and abilities. 7. Increase the number of times that the child is fed complementary foods as he or she gets older. 8. Feed a variety of foods to ensure that nutrient needs are met. 9. Increase fluid intake during illness, including more frequent breastfeeding, and encourage the child to eat soft, varied, appetizing favorite foods. After illness, give food more often than usual and encourage the child to eat more. WHO Guiding Principles for Complementary Feeding of the Non-Breastfed Child. 1. Ensure that energy needs are met. 2. Gradually increase food consistency and variety as the infant gets older, adapting to the infant's requirements and abilities. 3. For the average healthy infant, meals should be provided 4 to 5 times per day, with additional nutritious snacks offered 1 or 2 times per day, as desired. 4. Feed a variety of foods to ensure that nutrient needs are met. 5. Non-breastfed infants and young children need at least 400 to 600 milliliter per day of extra fluids in a temperate climate and 800 to 1200 milliliter per day in a hot climate. 6. Practice good hygiene and proper food handling. 7. Practice responsive feeding, applying the principles of psychosocial care. 8. Increase fluid intake during illness and encourage the child to eat soft, varied, appetizing favorite foods. After illness, give food more often than usual and encourage the child to eat more. WHO recommends the use of multiple micronutrient powders, or MNPs, for home fortification of complementary foods offered to infants and young children aged 6 to 23 months. Home fortification of complementary foods with MNPs comprising at least iron, vitamin A, and zinc is recommended to improve iron status and lower risk of anemia in this age group. MNPs can be considered as an alternative to supplementation to reduce anemia and iron deficiency in young children. The slide presents a suggested scheme to be recommended by healthcare providers for home fortification of complementary foods with MNPs. Use of MNPs is recommended in populations where the prevalence of anemia in children less than 2 years or less than 5 years of age is 20% or higher. 1 sachet per day comprising of iron, vitamin A, and zinc for a period of at least 2 months, followed by a period of 3 to 4 months without supplementation is suggested. Mild side effects such as darkened stools, gastrointestinal pain, diarrhea, constipation, and vomiting are often reported with iron supplementation. Although MNPs do not decrease these side effects, the frequency and severity of these are reduced. Moreover, MNPs are highly acceptable. Home fortification with MNPs has been reported to reduce anemia by 32% and iron deficiency by 50% in infants and young children compared to no intervention. The effects of MNPs did not significantly differ among populations with anemia rates ranging from 25% to 100%, or in malaria endemic settings. In settings where vitamin A deficiency is a public health problem, WHO recommends vitamin A supplementation in infants and children 6 to 59 months of age to reduce child morbidity and mortality. This is applicable to populations where the prevalence of night blindness is 1% or higher in children aged 24 to 59 months, or where the prevalence of vitamin A deficiency, as indicated by serum retinol levels equal to or less than 0.7 micromoles per liter, is 20% or higher in infants and children 6 to 59 months of age. The slide presents a suggested vitamin A supplementation scheme. Infants 6 to 11 months of age, including HIV-positive infants, can be given a single dose of 100,000 international units or 30 milligrams RE vitamin A as an oral liquid, oil-based preparation of retinol palmitate or retinol acetate. Children 12 to 59 months of age, including HIV-positive infants, can be given 200,000 international units, or 60 milligrams RE vitamin A every 4 to 6 months. All children diagnosed with measles should be given 1 dose of a vitamin A supplement. In settings with known vitamin A deficiency, or where measles case fatality is likely to be more than 1%, infants should receive 2 doses of vitamin A supplements given at 24 hours intervals to help reduce the risk of eye damage and blindness. Vitamin A supplements have been shown to reduce the mortality due to measles by 50%. The recommended age-specific doses are 50,000 international units for infants aged less than 6 months, 100,000 international units for infants aged 6 to 11 months, and 200,000 international units for children greater than or equal to 12 months. In case the child exhibits clinical signs of vitamin A deficiency, such as Bitot spots, a third dose should be given after 4 to 6 weeks. Although the measles vaccine is effective to reduce infant and child mortality, the vaccination coverage rates for measles is lower than that for DPT-3. According to evidence from Africa and Bangladesh, the introduction of the measles vaccine has led to a far greater reduction in overall child mortality than would be expected from reductions in measles mortality alone. WHO recommends 2 doses of measles vaccines, with the typical first dose being given between 9 to 12 months of age, with a usual interval of 4 weeks between doses. In 2016, the World Health Organization issued a new set of recommendations on iron supplementation in infants and children. These recommendations supersede those issued by WHO previously and pertain specifically to daily iron supplementation for infants and young children. The table on the slide presents the suggested scheme for iron supplementation in infants and children of different age groups. According to the revised guidelines, infants and children living in settings where the prevalence of anemia is 40% or higher should be provided iron supplements daily for 3 consecutive months in a year as a public health intervention. For infants and young children aged 6 to 23 months, it is recommended to provide 10 to 12.5 milligrams of elemental iron in the form of drops or syrups to prevent iron deficiency and anemia. For preschool-aged children aged 24 to 59 months, it is recommended to provide 30 milligrams of elemental iron in the form of drops, syrups, or tablets to increase hemoglobin concentration and improve iron status. For school-aged children aged 5 to 12 years, it is recommended to provide 30 to 60 milligrams of elemental iron in the form of tablets or capsules to prevent iron deficiency and anemia. In malaria-endemic areas, infants and young children should be provided iron supplements along with public health measures to prevent, diagnose, and treat malaria. Iron supplementation in such settings is not associated with an increased risk of clinical malaria or death if regular malaria surveillance and treatment services are provided. Oral iron interventions should not be provided to children if they do not have access to malaria prevention measures, such as provision of insecticide-treated bed nets and vector control program, prompt diagnosis of malarial illness, and treatment with effective anti-malarial drugs. WHO recommends zinc supplementation for diarrhea management. In developing countries, children with diarrhea should receive 20 milligrams per day of zinc supplementation for 10 to 14 days, or 10 milligrams per day for infants under 6 months of age. The 2008 American Academy of Pediatrics Vitamin D Supplementation Statement recommends that any breastfed infant, irrespective of whether he or she is receiving formula, should be supplemented with 400 international units of vitamin D, since it is unlikely that a breastfed infant would consume 1 liter of formula per day, an amount that would provide 400 international units of vitamin D. Similarly, any infant who receives less than 1 liter of formula per day should be supplemented with 400 international units per day of vitamin D. Further, a daily multivitamin or vitamin D-only preparation containing 400 international units of vitamin D would be warranted in older children and adolescents. In countries where less than 20% of households have access to iodized salt, all young children should receive iodine supplementation until the salt iodization program coverage is scaled up. Countries with household access to iodized salt between 20% and 90% should aim to increase iodine intake by the most susceptible groups through supplements or iodine-fortified foods. The recommended doses for children 6 to 23 months of age are 90 micrograms per day as a daily supplement, or 200 milligrams per year in a single annual dose of iodized oil. For children 0 to 6 months of age, iodine supplementation should be given through breast milk. The lactating mother is provided iodine supplementation while the child is exclusively breastfed. This slide concludes the essential nutrition actions recommended by WHO. Let us understand other dietary factors that are associated with nutrient deficiencies. Let us discuss important nutrition considerations for vegetarian children. The breast milk of vegetarian women is nutritionally comparable to that of non-vegetarians and is adequate. Commercial infant formulas are recommended if infants are not breastfed or are introduced complementary feeds before 1 year of age. Breastfed infants of mothers who have inadequate intake of vitamin B12 should receive a vitamin B12 supplement. Zinc supplements or zinc-fortified foods should be used when complementary foods are introduced. Intake of adequate energy and a variety of foods can meet protein needs in vegetarian children. Research has now proven that the body can assimilate all the essential amino acids consumed throughout the day, and that it is not required to consume complementary proteins at the same meal. Vegetarian diets are associated with a lower bioavailability of iron and zinc. Therefore, several measures can be incorporated to improve the bioavailability and enhance the absorption of these nutrients. The bioavailability of iron can be improved by fermentation processes. Phytate levels can be reduced, and iron and zinc absorption can be enhanced by leavening of bread, soaking and sprouting beans, seeds, and grains, and by including fruits and vegetables that contain vitamin C and other organic acids. This slide presents dietary strategies to prevent micronutrient deficiencies in children following vegetarian diet. Given that consumption of very restrictive or unbalanced vegetarian diets can lead to failure to thrive and serious nutrient deficiencies in infants and children, careful planning and provision of a mixed vegetarian diet, which includes milk and eggs, ensures the supply of essential energy, protein, and nutrient requirements at all stages of childhood growth and development. Where clinically indicated, infants and children should be provided alternative sources of dietary nutrients and supplements. The nutritional recommendations for children being weaned onto a vegetarian diet are presented in the table. Adequate protein content can be ensured by including more legumes, including bean and soy products, with higher lysine content compared with cereals. A variety of plant foods and cereal-legume combinations should be included to ensure 1.5 grams of protein intake per kilogram per day in children aged less than 4 years of age, and 1 gram of protein per kilogram per day thereafter. Inclusion of 20 to 25 grams of vegetable oil per day, or 40 to 50 grams of nuts per day, helps to increase energy intake by 25 to 30%. Providing 250 milliliters of vitamin D fortified soy milk ensures 1.5 to 3 micrograms of vitamin D per day. Providing 125 milliliters of vitamin B12 fortified soy milk ensures a supply of 0.9 to 1.3 micrograms of vitamin B12 per day. Children who follow a vegetarian diet will require 1 milligram of iron per kilogram body weight per day after 4 to 6 months of age. This can be ensured by including foods rich in iron, such as soy foods, legumes, nuts, cereals, and breads. Adding foods rich in vitamin C, such as citrus fruits, tomatoes, potatoes, spinach, and strawberries, increases the bioavailability of iron. To ensure adequate calcium intake, 6 to 12 servings of calcium-rich foods should be provided each day. Vegetarians can include 125 milliliters of calcium-fortified soy milk and reduce the intake of fibers to 0.5 grams per kilogram body weight per day to increase calcium absorption. As it may be practically difficult to do an accurate 24-hour recall to estimate fiber intake, vegetarians may require a dietitian's advice on supplementation and dietary adjustment. Let us now understand how to treat severe acute malnutrition in countries with a high prevalence of undernutrition. According to the 2013 updates by WHO on the management of SAM, infants and children aged 6 to 59 months who are identified to be malnourished by trained health workers in a community setting should be immediately referred to a treatment center for SAM for a full assessment. Infants and children who are identified to be malnourished by healthcare workers in primary healthcare facilities and hospitals should be immediately admitted to a program for the management of SAM. The WHO 2013 Guideline Update recommends that infants and children who are identified as having severe acute malnutrition should be first subjected to a complete clinical examination to identify whether the infant or child has an appetite and whether there are any medical complications. Infants and children who appear clinically well and alert and have appetite should be treated as outpatients. They can be managed at home or in a community setting with the use of ready-to-use therapeutic foods. Infants and children who have medical complications, severe edema or severe bilateral pitting edema, poor appetite, or one or more integrated management of childhood illness danger signs should be treated as inpatients. The danger signs include inability to drink or breastfeed, vomiting everything, presence of convulsions during examination, history of one or more prolonged convulsions lasting for more than 15 minutes, or lethargy or unconsciousness. Now let us discuss the community-based approach, which involves timely identification and treatment of severe acute malnutrition in children without medical complications. This approach involves the use of ready-to-use therapeutic foods or other nutrient-dense foods at home. Children should be fed with a ready-to-use therapeutic food till adequate weight gain is observed. In some settings, locally available nutrient-dense foods, along with added micronutrient supplements, can be used to prepare an appropriate therapeutic diet. However, very careful monitoring will be required when such an approach is followed, since it is hard to achieve nutrient adequacy. In addition to providing ready-to-use therapeutic food, RUTF, children should be provided a short course of basic oral medicines to treat infections, if any. They should be scheduled for a follow-up every week or every 2 weeks by a skilled healthcare worker in the community or in a clinic nearby. Ready-to-use therapeutic foods are ready-to-eat, high-energy, fortified foods that are suitable to treat severe acute malnutrition in children. They are soft or crushable and can be easily consumed without adding water by children over 6 months of age. The nutrient composition of these foods is similar to that of F100, the therapeutic diet used in hospitals, with the exception that they do not facilitate bacterial growth since they are not water-based. We will discuss the composition of Formula F100 in the subsequent slides. Nearly 10 to 15 kilograms of RUTF will be required over a period of 6 to 8 weeks to treat severe acute malnutrition. In the absence of any medical complications, a child aged greater than 6 months with severe acute malnutrition and appetite can be administered a standard dose of RUTF adjusted to its weight. The nutritional composition of ready-to-use therapeutic foods is presented in the tables. The composition of ready-to-use therapeutic foods includes moisture content, maximum 2.5%. Energy, 520 to 550 kilocalories per 100 grams. Proteins, 10% to 12% of total energy. Lipids, 45% to 60% of total energy. Sodium, 290 milligrams per 100 grams maximum. Potassium, 1,100 to 1,400 milligram per 100 grams. Calcium, 300 to 600 milligrams per 100 grams. Phosphorus, excluding phytate, 300 to 600 milligrams per 100 grams. Magnesium, 80 to 140 milligrams per 100 grams. Iron, 10 to 14 milligram per 100 grams. Zinc, 11 to 14 milligram per 100 grams. Copper, 1.4 to 1.8 milligram per 100 grams. Selenium, 20 to 40 micrograms. Iodine, 70 to 140 micrograms per 100 gram. Vitamin A, 0.8 to 1.1 milligram per 100 grams. Vitamin D, 15 to 20 micrograms per 100 grams. Vitamin E, 20 milligram per 100 grams minimum. Vitamin K, 15 to 30 micrograms per 100 grams. Vitamin B1, 0.5 milligram per 100 grams minimum. Vitamin B2, 1.6 milligram per 100 grams minimum. Vitamin C, 50 milligram per 100 grams minimum. Vitamin B6, 0.6 milligram per 100 grams minimum. Vitamin B12, 1.6 micrograms per 100 grams minimum. Folic acid, 200 micrograms per 100 grams minimum. Niacin, 5 milligram per 100 grams minimum. Pantothenic acid, 3 milligram per 100 grams minimum. Biotin, 60 micrograms per 100 grams minimum. N6 fatty acids, 3% to 10% of total energy. N3 fatty acids, 0.3% to 2.5% of total energy. Now let us discuss the hospital-based management of infants and children with severe acute malnutrition. WHO has laid out guidelines for the hospital-based treatment of severe acute malnutrition. According to these guidelines, severe malnutrition is defined as the presence of severe wasting, that is, less than 70% weight for height, or less than -3 standard deviation and/or edema. The general principles, or the 10 essential tips for routine care during severe acute malnutrition include: prevent or treat hypoglycemia. Prevent or treat hypothermia. Prevent or treat dehydration. Correct electrolyte imbalance. Prevent or treat infection. Correct micronutrient deficiencies. Start cautious feeding. Achieve catch-up growth. Provide sensory stimulation and emotional support. Prepare for follow-up after recovery. In today's presentation, we will focus on the nutritional interventions in the management of SAM, which are indicated as dark blue boxes. It is recommended that these steps be accomplished in 2 phases. An initial stabilization phase. This phase concentrates on managing the acute medical condition during the initial 7 days. A longer rehabilitation phase, which extends for 2 to 6 weeks. The approximate timescale for each phase is presented in the table. Let us discuss the nutritional interventions in detail in the subsequent slides. The treatment is usually accomplished in 2 phases, an initial stabilization phase and a longer rehabilitation phase. During the initial stabilization phase, the acute medical conditions are managed. The approximate timescale required for each of the treatment steps is presented in the table. Hypoglycemia, hypothermia, and dehydration are managed during the first 2 days. Treatment for correction of electrolyte imbalance usually takes nearly 2 to 6 weeks. Infection is managed during the initial 3 to 7 days of the stabilization phase. Treatment for micronutrient deficiencies usually begins from the stabilization phase and extends up to 2 to 6 weeks. Treatment with iron supplements is not recommended during the initial stabilization phase until the child has a good appetite and regains weight. Cautious feeding should be initiated from day 1 and continued up to days 3 to 7. Maintenance of catch-up growth is usually taken care of during the rehabilitation phase, during which time a vigorous feeding approach is required to achieve very high intake and rapid weight gain of greater than 10 grams gain per kilogram per day. Children should be provided sensory stimulation and emotional support from day 1 up to 2 to 6 weeks of rehabilitation phase. Preparation for follow-up after recovery is usually planned during the rehabilitation phase. The initial 2 steps are to prevent or treat hypoglycemia and hypothermia, respectively. The 3rd step is to prevent or treat dehydration. Therapeutic strategies include administration of Resomal 5 milliliter per kilogram every 30 minutes for 2 hours orally or through a nasogastric tube. Over the next 4 to 10 hours, Resomal 5 to 10 milliliters per kilogram per hour should be administered. The exact amount of Resomal should be based on the child's needs, loss of stools, and vomiting. If signs of rehydration are evident at 4, 6, 8, and 10 hours, the Resomal doses at these hours should be replaced with F75 feeds, and starter F75 feeds should be continued. Full-strength standard WHO low osmolarity oral rehydration solution containing 75 millimoles per liter of sodium should not be used for oral or nasogastric rehydration in children who present with some dehydration or severe dehydration. These children should be fed with either Resomal or half-strength standard WHO low osmolarity oral rehydration solution with added potassium and glucose, unless the child has cholera or profuse watery diarrhea. Children suspected of having cholera or with profuse watery diarrhea should not be given Resomal. Instead, they should be given standard WHO low osmolarity oral rehydration solution that is normally made, that is, not further diluted. Children with severe acute malnutrition and signs of shock or severe dehydration, and in whom rehydration cannot be achieved orally or through the nasogastric tube, should be treated with intravenous fluids. It is important to remember the following points during the treatment of dehydration. In children with severe malnourishment, estimation of dehydration status using clinical signs alone is difficult. Sodium content of the WHO low osmolarity oral rehydration solution has been reduced from 90 millimoles per liter to 75 millimoles per liter. Monitor the progression of rehydration by assessing pulse rate, respiratory rate, urine frequency, and stool or vomit frequency every 30 minutes for 2 hours, and then every hour for the next 6 to 12 hours. Serum phosphate tends to decrease during the first few days of refeeding in children with severe acute malnutrition, reaching a nadir around 2 to 4 days of refeeding. Monitoring electrolyte disturbances may not be feasible in all treatment centers in developing countries. Hence, in order to prevent hypophosphatemia in all treated children, standard treatment should be trusted without the need for monitoring of plasma phosphate. This may include nutritional rehabilitation with phosphorus-fortified F75 that complies with the UN specifications. According to the UNICEF specifications, pre-mixed F75 should be fortified with phosphorus to provide 73 milligrams per kilogram per day of phosphorus when fed at 130 milliliters per kilogram per day. Rapid breathing and pulse indicate overhydration and coexisting infection. Stop fluids immediately and then reassess child after an hour. The composition of Resomal oral rehydration solution is as follows. Boiled and cooled water, 2 liter. WHO ORS solution, 1 1-liter packet. Sugar, 50 grams. Electrolyte or mineral solution, 40 milliliter. The Resomal contains approximately 45 millimoles per liter of sodium, 40 millimoles per liter of potassium, 3 millimoles per liter of magnesium. In a child with continuing watery diarrhea, dehydration can be prevented by feeding with starter F75 formula and administering rehydration solution for malnutrition, or Resomal. About 50 to 100 milliliters of Resomal can be given as a guide after each watery stool. Breastfeeding should be encouraged if the child is breastfed. The fourth step is to correct electrolyte imbalance. Despite low plasma sodium levels, severely malnourished children have excess sodium in their bodies. High sodium load in such children can be fatal. Further, the potassium and magnesium levels are deficient. These electrolyte imbalances may partly contribute to edema. Diuretics should not be administered to such children to treat edema, as it can be fatal. Electrolyte imbalance can be corrected by giving extra potassium at 3 to 4 millimoles per kilogram per day, extra magnesium at 0.4 to 0.6 millimoles per kilogram per day, preparing food without salt, and giving low-sodium rehydration fluid, such as Resomal, during rehydration. The extra potassium and magnesium can be prepared in a liquid form and added directly to feeds during preparation. The fifth step is to prevent or treat infections. Specific antibiotics should be administered in the presence of specific infections. The sixth step is to correct micronutrient deficiencies. Vitamin and mineral deficiencies are common in all severely malnourished children. If there is definite evidence that vitamin A has not been administered in the previous month, then administer vitamin A on day 1. The dose is 50,000 international units for infants aged 0 to 5 months, 100,000 international units for children aged 6 to 12 months, and 200,000 international units for children aged more than 12 months. Additionally, for at least 2 weeks, give multivitamin supplement, zinc 2 mg per kilogram per day, and copper 0.3 mg per kilogram per day. Give folic acid 5 mg on day 1 and then continue with 1 mg per day. Iron should be administered at a dose of 3 mg per kilogram per day, only if there is evidence of weight gain. A high dose of vitamin A supplementation is not required if children are receiving F75, F100, or ready-to-use therapeutic food that complies with WHO specifications, or if vitamin A is part of other daily supplements. Points to remember. Anemia is common in children with severe malnutrition. However, do not give iron initially, as it can worsen infections. Wait until the child regains a good appetite and starts gaining weight, which usually occurs by the 2nd week. The 7th step is to start cautious feeding. Cautious feeding is essential during the stabilization phase, since the child's physiological state is fragile and the homeostatic capacity is reduced. Children should be started on feeds immediately after admission. Children should be fed frequently in small amounts, with feeds of low osmolarity and lactose, and through orally or through nasogastric tubes, and never parenterally. The feeds should provide 100 kilocalories of energy, 1 to 1.5 gram of protein, and 130 milliliter of fluid per kilogram body weight per day. If the child has severe edema, then the feeds should provide 100 milliliter per kilogram per day of fluid. Breastfed children should be continued on breast milk and should additionally be given prescribed amounts of starter formula to ensure that their requirements are met. For most children, milk-based formulas such as Starter F75, which contains 75 kilocalories per 100 milliliters, and 0.9 grams protein per 100 milliliters, are sufficient. F75 is used during the initial phase of treatment, while F100 is used during the rehabilitation phase. In the cautious feeding stage, a number of feeds offered and the amount left over, vomiting, frequency of watery stools, and daily body weight should be monitored and noted. The recommended schedule in which the volume of feeds is to be gradually increased and the frequency gradually reduced is provided in the table. This feeding schedule can be accomplished in 2 to 3 days in children with a good appetite and no edema. The WHO F75 starter formulas comprise 300 milliliters of fresh or long-life full cream cow's milk, or 35 grams of full cream dried milk, 100 grams of sugar, 20 grams or milliliters of vegetable oil, 20 milliliters of electrolyte or mineral solution, and water to make up to 1,000 milliliters. The F100 catch-up formula comprises either 110 grams of full cream dried milk, 50 grams of sugar, 30 grams or milliliters of vegetable oil, 20 milliliters of electrolyte or mineral solution, and water to make up to 1,000 milliliters, or 880 milliliters of full cream cow's milk, fresh or long life, 75 grams of sugar, 20 grams or milliliters of vegetable oil, 20 milliliters of electrolyte or mineral solution, and water to make up to 1,000 milliliters. The 8th step is to achieve catch-up growth. Children should be transitioned to the rehabilitation phase if there is evidence of a return of appetite, which usually occurs after about 1 week of admission. The transition should be initiated slowly to avoid the risk of heart failure. In order to change from starter F75 formula to catch-up F100 formula, replace the starter formula with the same amount of catch-up formula for 48 hours. Subsequently, each successive feed can be increased by 10 milliliters until the child leaves back some amount of the feed uneaten. During the transition, it is important to monitor the respiratory and pulse rates for signs of heart failure. If the respiratory rate increases by 5 or more breaths per minute, and if the pulse rate increases by 25 beats or more per minute during 2 successive 4-hourly readings, then the volume per feed should be reduced. Give F100 every 4 hours at 16 milliliters per kilogram per feed for 24 hours, followed by 19 milliliters per kilogram per feed for 24 hours, 22 milliliters per kilogram per feed for 48 hours, and subsequently increase each feed by 10 milliliters. After the transition, give unlimited amounts of catch-up formula feeds frequently, at least every 4 hours, to provide 150 to 220 kilocalories of energy and 4 to 6 grams of protein per kilogram body weight per day. Encourage the mother to continue breastfeeding if the child is breastfed. After the transition, monitor the progress by assessing the rate of weight gain. Plot the weight of the child each morning before feeding. Calculate and record the weight gain every week as grams per kilograms per day. If the weight gain is poor, that is, less than 5 grams per kilogram per day, assess the child thoroughly. If the weight gain is moderate, that is, 5 to 10 grams per kilograms per day, check whether the intake meets the required target or for occult infection. If the weight gain is good, that is, greater than 10 grams per kilogram per day, then encourage the mother and staff. Step 9 includes providing sensory stimulation and emotional support. Children with severe malnutrition have delayed mental and behavioral development. Hence, it is important to provide tender, loving care, a cheerful, stimulating environment, structured play therapy for 15 to 30 minutes daily, physical activity as soon as the child recovers, and maternal environment such as feeding, bathing, comforting, and playing when possible. Children who are treated on an inpatient basis can be transferred to outpatient care if there is evidence of resolution of their medical complications, including edema, if they have regained appetite and are clinically well and alert. A decision to transfer a child from inpatient to outpatient care should be based on the child's clinical condition and not on specific anthropometric outcomes, such as a specific mid-upper arm circumference or weight for height or length. Children with severe acute malnutrition should be discharged from treatment only when the weight for height or length is greater or equal to -2 z-score, and there is no edema for at least 2 weeks, or if the mid-upper arm circumference is greater than or equal to 125 millimeters, and there is no edema for at least 2 weeks. Additionally, the anthropometric indicator that was used to identify severe acute malnutrition, that is, mid-upper arm circumference or weight for height z-score, should be used to determine whether a child has reached nutritional recovery. Children admitted with only bilateral pitting edema should be discharged from treatment based on whichever anthropometric indicator, mid-upper arm circumference or weight for height, is routinely used in programs. Discharge criterion should not be based on percentage weight gained. The last step is to prepare for follow-up after recovery. Caregivers should be advised to continue good feeding practices and sensory stimulation at home, bring the child back for regular follow-up visits, and ensure that the child gets all booster immunizations and vitamin A every 6 months. Parents or caregivers should be shown how to feed frequently with energy and nutrient-dense foods and practice structured play therapy. Children with severe acute malnutrition who are discharged from treatment programs should be periodically monitored to avoid a relapse. We have come to the end of this module. Let us review some key aspects of this presentation. Undernutrition during the early years of a child's life can exert significant short and long-term health consequences. The prevalence of micronutrient deficiency is high in countries with high rates of undernutrition. Therefore, Prevention and treatment strategies are crucial in tackling this global burden. Careful planning and a mixed vegetarian diet can provide essential energy, protein, and nutrients required at all stages of childhood growth and development. Interventions such as delayed cord clamping, vitamin K administration, vitamin A supplementation, and kangaroo mother care can prevent nutrient deficiencies in neonates. Breastfeeding. Promoting dietary diversity and complementary feeding, providing iron, vitamin A, zinc, and multiple micronutrient supplements, and deworming can prevent nutrient deficiencies in infants and children. Severe acute malnutrition can be identified in a community setting by measuring the MUAC and by examining for bilateral pitting edema. In primary healthcare facilities and hospitals, SAM can be identified by assessing the MUAC, or the weight for height or length status, and the presence of bilateral edema. Infants and children who appear clinically well and alert and have appetite should be treated as outpatients. Infants and children with medical complications, severe edema, or severe bilateral pitting edema, poor appetite, or one or more integrated management of childhood illness danger signs should be treated as inpatients. The WHO 10 essential steps should be followed during hospital-based treatment of severe acute malnutrition.